I did, actually, name's Robert Marks. Yeah, I did a year of general surgery up actually at Stony Brook as a prelim before I came here as a categorical, and loved the department, but went over to anesthesia with the intention of doing pain, or at least the hope to do pain. So I'm here to talk about pain management for the non-pain specialist. Basically, I've got a few different objectives, but my primary objective, although I don't actually have it in writing, is to not get overly complex on you guys. Basically, I want to be able to give a lecture that not only doesn't put people to sleep, but actually has something to be able to take away from it. I mean, I'm not going to sit and talk about the complexities of what types of neurons exist and all the sorts of other just complex stuff that makes no difference in clinical practice. Basically, I want to make something that's going to really be somewhat beneficial for everybody. So first off, I'll kind of discuss how to think about pain. Really, back when I was doing surgery, I didn't really have a clue how to think about pain. I never really thought twice about any of it. It's just, you know, somebody hurts and you make them feel better. Then I want to talk a little bit about what a pain specialist does, because most people think you just kind of send the annoying patients to the pain guy and that's it, and they just sort of disappear. But at least give you guys an idea about what exactly we offer. And then also principles of managing patients with pain. There's a lot of little things that any practitioner, including surgeons certainly, can do, as well as considerations upon admission and discharge. So first off, in order to talk about pain, it's imperative to define what is pain. Well, the IASP, International Association for the Study of Pain, describes it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Basically, what you take out of that is something hurts, and it may really be broken, it may not be broken. You stub your toe, but everything's fine, but it still hurts. The other thing, though, to consider when you talk about what is pain is that you have to realize that it's 100% subjective. And in fact, pain management is one of the only fields where we don't do anything objective. Well, with some exceptions, but for the most part, we're treating a subjective issue. You can't diagnose pain by a CAT scan. And we all know you see an MRI of somebody and you look and you say that should really hurt, but they don't hurt. And then the normal MRIs hurt like crazy. So we have to sort of describe the mechanisms a little bit, and I'm going to be very, very, very basic in terms of the mechanisms, because there's a lot of complexities. But once again, in order to really understand the basis of it, you have pain, you have some sort of occurrence that takes place somewhere in the body, which is transduction. It subsequently is transmitted along a peripheral nerve to the spinal cord and up to the brain. Simple enough, right? So in talking about these, though, transduction, it's the concept of basically one type of signal being converted to another type of signal. The anesthesia nerds in here, including myself, will appreciate concepts like the transducer cable on an A line. It's something that converts the pressures into an electronic signal that then tells our monitors what a pressure is. Well, transduction is basically what happens when the nociceptors or the pressure receptors, whatever receptors they are, converting a signal to be able to send along a neuron. So next up is the transmission. This is where the actual signal that was converted from the transducers is going up a peripheral nerve to the spinal cord, and basically action potential propagating the sensory nerve ending to the second order cells in the dorsal horn. Fine, not getting into the details about second order cells or anything, because it's not really clinical for what we're talking about today. Modulation takes place, and we all kind of know and you hear about this, as you have the signals that come from the brain going, basically giving efferents and accepting afferent signals to basically alter the nociception, altering the pain that's actually taking place. This is the kind of thing that happens, the reason when somebody goes into a battlefield knowing they're going to die and they don't necessarily feel pain. They've got so many other things going on that's taking place that they don't notice it and it doesn't bother them. And then finally, perception. And in terms of the type of perception that you have from pain, there's more than just it hurts. There's different parts of the brain that are telling you different things. Where is the pain? How intense is the pain? What kind of fear and anxiety should we have secondary to the pain? And then, of course, when we talk about the pituitary hypothalamic responses, which I'm not getting into, but we all know the patients that come into the burn unit and the types of reactions that take place. The reason we put them on beta blockers, those reactions can be pretty intense in terms of the stress response. So something else that you need to kind of have a little bit of a basis on is the gate theory, because people make reference to this. Now, this is a very, very, very basic concept here, and it's not 100% the case, but it at least explains a little bit about what people talk about sometimes when it comes to pain. And these are images that kind of came from a little animation. But the idea behind the gate theory, just to be aware of, is basically like this. If you were to hit your thumb with a hammer, you have your nociceptor neurons that are basically going up to the spinal cord, and they're continuously sending a signal, which is what's taking place in that bottom picture. Those are small little nerve fibers. They transmit quickly, and what happens, with the gate theory at least, is there's this little inhibitory interneuron that's able to get activated if you have mechanoceptor fibers being activated, which is the reason that when you stub your toe or you hit your thumb with a hammer, sometimes you'll sit there and you start rubbing your hand. And that overstimulation that takes place as you're rubbing your hand or rubbing your toe basically is so much more intense in terms of the number of signals that are taking place that it starts to outdo the actual nociception. Basically, it makes it so that you don't feel the pain. That's the principle of the gate theory. This is also the way there are other complexities that are involved, but when you hear about people using TENS units or spinal cord stimulation, things that are basically giving some sort of current and some sort of stimulation that takes place to overwhelm the nociceptive fibers, to overwhelm the actual pain sense, so that instead you feel something else, or basically you don't feel the pain. So that's the gate theory. So let's talk a little bit about the types of pain that people actually have. And once again, I don't mean to be so basic. A lot of this stuff may seem obvious, but at the same time, it's not all of it. I was kind of surprised when I started studying pain as an anesthesia resident and realized how much I really didn't know. So we all know about nociception. It basically starts at pain receptors. It's something that really hurts. We all know about somatic, we all know about visceral. Certainly you guys know about visceral pain with as much abdominal surgery as you guys do. But what about neurogenic pain? Basically, neurogenic pain is pain that starts at the nerve itself, usually described as burning, tingling, electric. It can be localized or referred. So, you know, there was a patient that I saw with buccal carcinoma of Dr. Cordero's, who I was consulted on when I was a pain fellow here, and he said his pain was a 10 out of 10. He was on a fentanyl patch, he was on a PCA with morphine, I think it was like 1 milligram every 6 minutes, plus he was getting oral Lortab, and he said his pain was a 10 out of 10. I went in and I said, what's going on? What exactly? Describe your pain. He said, it's this burning sensation. Well, that explained it. We started him on Lyrica and his pain went away. It wasn't a somatic or visceral pain, it was a burning, it was a neurogenic pain. Neurogenic pain basically just comes straight from a nerve. There's also psychological pain, which is sort of, it has its complexities, but certainly a lot of patients that have chronic pain are depressed or they've got other sort of psychological issues, and that can certainly create an actual pain that patients are sincerely feeling. Another distinction that we need to be able to make is acute pain versus chronic pain. And this also is something that when I first started, and you guys, this is almost the bane of the existence of the acute pain service and the chronic pain service, because I remember how many conversations I had with surgery when you guys would call acute pain, we'd say call chronic. But it's actually an important distinction. There's actually a basis to this distinction, and that is that acute pain is useful. The idea behind it, you hear Dr. Day will say, oh, chronic pain is after 6 months. Or chronic pain is going to be, you know, some books will say 3 to 6 months, whatever. It's not necessarily so much a time frame, but it's the idea that the acute pain is telling you that there's something that's broken, there's something that needs to be fixed. If you pick something up and your back goes into spasm, that's an acute pain, and it's telling you something, and it's telling you something that's important. And you can expect that to change. And for that reason, you treat the cause. And as surgeons, you guys treat the cause of acute pain all the time. That's the reason I say it's your job, usually. Chronic pain, on the other hand, is when you've basically given up on the fact that you're going to be able to treat the cause. You're probably not going to be able to get rid of the thing that is causing the pain, whether that's an actual problem with the nerves themselves or just a physiologic basis, you've spinal stenosis or something that's really going on that's not going to go away, but it's not doing anything good for the patient. And that's where we come in. That's where we want to treat the symptoms instead of the cause. That's my job. That's the pain management specialist job. So let's make a couple of examples here of acute pain versus chronic pain. Acute pain, and these are things that generally you guys would see, and I tried to make this appropriate for general surgery. Early cancer pain. Somebody comes in, they first have cancer, they were just diagnosed. You might be able to resect some of it, you might not. You haven't given up and thrown in the towel. That's why that might actually be acute pain. At the same time, if they've got osteosarcoma and it's metastatic, that would pretty much be considered a chronic pain. It's not going away. And this is where I think that the 6-month discrepancy, you can't necessarily always go by. But for the most part, it's a good rule of thumb. Postoperative pain is generally acute unless you have a patient who already had chronic pain. acute fractures, back strain, all these various things, including early burns. And that's also an important distinction, early burns versus late burns. Somebody who had a burn 2 years ago who comes in, they've got chronic pain from their contractures, very different story than when they first come into the hospital. In terms of chronic pain, you see kind of the list there, and I'm not going to read through the whole list, but some things, though, that you guys as surgeons should certainly be aware, and they're things that we do see in the pain clinic and we do treat, post-thoracotomy syndrome. Patients have the ribs that come out, they end up with, whether it's a neuroma or whether it's something that's going on that's causing chronic pain from the ribs. Post-herniorrhaphy pain, ilioinguinal whatever it is. Crohn's disease. You guys hate Crohn's disease because you have to operate them over and over and over again, and they just never let you go. But they also have chronic pain in their abdomen that needs to be treated, and we're able to do that. Certainly failed back surgery syndrome and late burns, whatever. There's a lot of types of chronic pain. But that's sort of the discrepancy between the two and sort of a way to think about pain, at least. So who cares about the distinction? Basically, it requires the understanding of what exactly a pain specialist does, because we're not just glorified drug dealers. Frankly, we're not drug dealers at all, as far as I'm concerned. We are truly treating a real pathology and trying to help people. So what does a pain specialist do? We try to decrease the patient's perception of their pain. Basically, we don't want them to suffer. We want to be able to improve their quality of life so that they're able to enjoy having the opportunity to go to church, having the opportunity to be able to hold their grandchildren. We're not necessarily making them live longer. It's one of the few fields of medicine that is truly there to make people enjoy the time that they have and not necessarily enhance the time that they have. And honestly, that's the reason that I love it so much. It's the most rewarding feeling to be able to see that you can really make people smile that haven't been able to for that long. And why is that? It's because the pathology is not going anywhere. So we might as well eliminate the sensation, basically get rid of that negative response that takes place. So everybody says, so that's why you guys just give a bunch of shots. Well, there's a lot of other things that we do too, and I will talk about them after the kinds of shots that we give. But the idea behind the injections that we do, because once again, it's something that I think is good for people to just have some idea of what exactly we're doing, is that most every pain does involve a nerve of some sort. And I always like to give the hammer on the thumb example. If there's a hammer, a nail that's actually going through the thumb, you know exactly where that pain is coming from. But your thumb might hurt from an injury to the brachial plexus. Your thumb may hurt from something that's going on, some sort of pathology in the cervical spine. Your thumb may hurt because you've got pathology going on in your brain. All of those things might hurt your thumb. And so the pain specialist, when you have a patient with chronic pain, can weed all of those things out and figure out exactly where is the etiology of the pain really coming from. So what I do, and the way I like to explain it to people, and generally speaking what pain guys do, you start distally. And you always hear about these diagnostic blocks. So if somebody's thumb hurts, first you'll do a diagnostic block, maybe block the nerve that goes directly to the thumb. If that knocks out the pain, cool, then it's not coming from the neck and it's not coming from the brain. If you simply did a nerve block just proximal to the thumb and the tip of the thumb no longer hurts, you know where that's coming from. But you work your way up proximally when it comes to interventional pain specialties. And what if the block does kill the pain? This is where you look at the different modalities that we have. And there's a lot of modalities that pain management guys have. You can burn the nerve. If you burn the nerve, it basically permanently destroys that nerve. And I'd say permanently until it grows back. The books say 9 to 24 months. My experience probably more like 9 to 12 months. I mean, sometimes it does last longer, but that's what I generally tell patients to expect. It removes all of the function of the nerve, however. It destroys motor and sensory function when you do radiofrequency thermocoagulation because you're burning it at 80 degrees Celsius. Freezing it, cryoneurolysis, lasts less time. It destroys parts of the nerve, but you still remove all of the function of the nerve. Because parts of the nerve still stay intact, it grows back more rapidly, and therefore it only lasts about 6 to 9 months. And then finally, you can stun the nerve. And where I wrote on there 64999, that is the bane of many people's existence in the world of surgery. And I don't know if all the residents necessarily know. I didn't know until recently. But basically, it's been deemed experimental in the United States. Used to be done very frequently. The beauty of Polestar FTC is it pulse burns a nerve at 42 degrees Celsius and basically stuns it so that you don't have sensory sensation, but you still have motor. So if somebody has pathology to the femoral nerve that's causing pain, or pathology distal to it that you basically want to knock out that stimulus going through the femoral nerve, you can pulse RF it, and it's going to make it so they don't feel it, but their femoral nerve will still function in terms of motor. So what if the blocks are useless? There's also neuromodulation. You guys hear a lot about this. Spinal cord stimulation, basically based in the most simple way to explain it on that gate theory. There are also other bases of why it works. Peripheral nerve stimulator, kind of a similar concept, but really you'll put it peripherally, and it's only when the pain is isolated to one specific nerve. Also intrathecal pumps. This is basically where you actually put in a spinal, it's basically a spinal pump. It's like a continuous spinal block, and you'll use a highly concentrated drug. FDA approved are baclofen and morphine. And there's also one called Prialt, which is some sort of snail, not venom, it's something from a snail. But actually does work, but it's got such bad side effects you don't really hear about it very often. Those are alternatives to high doses of oral medications. When you have a patient with, let's say, cancer, and they're taking such a large amount of narcotic that it becomes dangerous, that's something that you guys could certainly consider referring to pain management and saying, hey, this guy has 6 months to live and is suffering and really might benefit from an intrathecal pump. In my practice, I find that that is probably, or at least my practice that I'm shortly going to begin, I find that that's actually one of the most rewarding kinds of pain management that you can do is the cancer patients that don't deserve what they have, and it's not their fault that they have it. And if you're able to put a pump in them and be able to really optimize their comfort level and their end stage of life, that's amazing. So it minimizes the adverse effects of the medications. So of course there's non-invasive stuff too. Not every pain patient is really an appropriate person to go and start putting a bunch of needles in. So of course there's physical therapy. I'll send any patient to physical therapy because if it works, it's great. You get a decent amount of bang for your buck. People can learn how to do these things at home. Stretching, strengthening, TENS units, desensitization, massage, whatever it is. If it feels good and makes their pain better, awesome. Weight loss is certainly an issue, and we see this getting to be more and more of a problem here in the United States because we've got such a largely obese population. If somebody's 350 pounds and their low back hurts, you probably aren't going to fix that really well with pills if weight loss is an option. Improved sleep is something that I don't think we focus often enough. I know there's a lot of talk coming up within hospitals in terms of how well are patients sleeping in the middle of the night when they've got all their alarms going off and people are walking in and out of the rooms. But sleep certainly has a lot to do with pain, and it corresponds to the psychological component. I'm not a psychiatrist. I can tell you a little bit about all these things, but I'm not going to because I'm not a psychiatrist. If somebody needs to go see a psychiatrist for their pain, I will be happy to refer them to it. And then, of course, there's pain medicines. And pain medicine is a lot more than just narcotics. Narcotics might block the receptors and actually decrease the sensation of pain, but there are ways to do other things. Anticonvulsants will actually alter the way the signal is transmitted through a nerve. Lyrica and Neurontin are really very commonly given drugs now, and we'll use those for neuropathic types of pains. Muscle relaxers are good if somebody has a muscular component. I know that you guys use a lot of Robaxin and Flexeril. I will say, actually, Xanaflex is an alpha-2 agonist. It works similarly to clonidine, which has a central method of decreasing pain. Xanaflex also has been shown to decrease the muscle tension. What I also like about it, though, is one of the anesthetic drugs that we use, and you guys know this from the ICU, is dexmedetomidine. And you know that you like to use that to be able to keep patients sedated while they're on a ventilator because they keep breathing. And that's the best thing about Xanaflex. They will keep breathing. And I like that about that. NSAIDs and Tylenol, obviously great drugs. Narcotics, I'll talk a little bit about narcotics at the end. I mean, it's just a bunch of variations of things that alter the reception of pain. Marijuana, if you guys you don't want me to get on my soapbox of marijuana, I'm actually giving a grand rounds at MD Anderson in a couple of months about marijuana. It's an issue that I think, or a topic that I think is not discussed nearly enough. And I think that within the next 10 years, I'm confident that we'll actually start seeing a lot of changes in terms of laws, not just because of whether it's a matter of literature coming out that supports it, but moreover just where we're at in terms of the dangers and the legalities in the 17 states that currently legalize it for medicinal purposes. It's something that I think that we cannot ignore, although due to the Medical Practice Act in the state of Texas, I cannot and will not allow my patients to smoke marijuana or use marijuana secondary to the fact that it is in fact an illegal substance. And then of course there are other things which I won't really get into here. This I thought was kind of a cool slide. I actually took the pain boards last Saturday, and when I was studying I saw this on one of the lectures. This is basically COX-2 versus COX-1 ratios. The further to the left something is, the more COX-2-ish it is. The more to the right, the more COX-1-ish it is. So you see where aspirin is. You see where like rofecoxib, which I think was rofecoxib, I believe that was Bextra. Certainly we know it's off the market. You see Celebrex is highly COX-2. But anyway, what I thought was really interesting in it though was seeing like Ketorolac is far to the right. That's Toradol. We give that, and we always talk about, is that going to worsen bleeding intraoperatively? Well, I don't know to what extent. There's certainly other issues that take place with it, but when you see how far to the right one drug is compared to another, and you compare that to things like aspirin, I think it gives an interesting perception. One of the other things that I also learned actually from taking the pain boards over the weekend is that ibuprofen will actually have a negative impact on the ability for aspirin to be cardioprotective. And for what it's worth, I missed the question on the exam, but when I looked up the interactions on Medscape, I saw that it actually has a warning that ibuprofen should not be given to patients who are taking aspirin for cardiac protection. Never knew that. So in terms of the physician's role, this is you guys' role. When you have a patient that comes into the hospital, and this is what I want you guys to really try to think about, is how can you prevent acute pain from becoming chronic pain? First off is preemptive analgesia, and I'll talk a little bit about that. Maintaining patient comfort. This is as simple as continuing the patients on their home pain regimen. I'll talk a little bit about that as well. And also discharging the patients on an appropriate pain regimen. I remember so many times when I was an intern, we would convert a patient, Candy would say, hey, let's go ahead and DC the PCA, convert them to oral pain medicine, and get them out the door. And I would have no idea how much of the PCA they were really using. They might have still been in some pain. And I'd look and I'd say, okay, let's go ahead and, I don't know, Lortab 7.5, one every 6 hours, and we'll give them 30 of them, and come follow up with whoever that person was in 2 weeks in the trauma clinic. And I had no clue what I was doing. And sometimes we go with 5, sometimes we go with the 10s, sometimes we give 30, sometimes we give 90, sometimes we'd say 1 every 6, sometimes we'd say 2 every 4. There was no real rhyme or reason to what we would do, and maybe that's just me, but I know there wasn't exactly much education in this regard back in the day. So I'm going to talk a little bit about how to convert somebody from a PCA to oral. Also, don't hesitate to consult the pain specialist to help optimize things if needed. There's a lot of things you don't always need to consult. Sometimes just call and say, hey, what do you think of this? Cool, we can do things, we can help. So first I'll talk a little bit about preemptive analgesia. This is kind of the same basis of what I was talking about earlier with the different types of transmission, transduction, all those different things. But in terms of looking at preemptive analgesia, you have to recognize the fact that local anesthetics and anti-inflammatories, when you look from where the trauma is, that's you guys. That's where you guys can inject local on the wound site before you make your incision, preventing the initial transmission of that signal from making it up to the brain, preventing the sensitization, preventing the larger action potentials which actually create sensitization and windup, which is a bunch of fancy talk for if it hurts really bad at the beginning, it's going to continue to hurt more than it would at the start. So local anesthetics being given at the wound. Local anesthetics and the peripheral nerve, that's basically a regional nerve block. We do those, anesthesia people do those all the time for a lot of the orthopedic cases. Has a lot more efficacy if it's done preoperatively than postoperatively, but we still do them postoperatively. Local anesthetics, opioids, and alpha-2 agonists given in the dorsal horn, that's basically spinals, epidurals. Certainly you guys ask us for epidurals a lot. Rib fractures, thoracotomies, prostate surgery. There's a lot of benefits from those. But basically, and then of course there's stuff that goes up in the brain. That's something that you can't really necessarily do with blocks or catheters or whatever, but it still has an impact when you give different drugs. But the idea behind this, and what you should really take home from this, is local anesthetics, basically numbing medicine, can be given in all these different areas to be able to prevent those nerves from being able to send that signal to the brain. You could do it far distally, you could do it proximally. So there's some studies that have come out, and this is just one of them. This is actually from 2005 from Anesthesia and Analgesia, basically talking about preemptive analgesia. And what they did is they took, how many studies was it? I actually wrote it down here. This is a meta-analysis of 66 studies, a total of 3,261 patients with preemptive analgesia. And basically what they determined, based on outcomes of 3 different parameters: pain score improvement, the amount of supplemental anesthesia that they needed, or analgesia that they needed, and also the time that it took until they requested their first analgesic. And what they found was that epidural and NSAIDs were the 2 most efficacious if given preoperatively for preemptive analgesia. And then also they found that the utilization of local anesthetic, basically skin infiltration, was also highly efficacious. What did not work as well was NMDA antagonists, which I won't get into, and systemic opioids. Not really too surprising, because all it's really doing is blunting the receptors, blunting somebody's perception of pain. The other things are actually decreasing inflammation and decreasing the signal from actually making it to the brain. So preemptive analgesia, basically you look at kind of the different places where you're able to first give preemptive analgesia. Local infiltration, once again, emphasizing to you guys that if you inject local before you make your incision, it can be very easy and quite beneficial. And I'll also point out, and a lot of you guys who were here when I was an anesthesia resident will also remember this, when you guys are doing gallbladders, and I'll say, hey, you guys go ahead and give local when you guys are closing, and you guys would, and I would extubate the patient while you guys were still closing. And the reason is because the patient wouldn't feel it. And then I just tell the patient, since they're behind the drape, they're just putting dressings on. Why is that good for you guys to know? Because if you're able to have an anesthesiologist who extubates while you're still closing, that's going to decrease your turnover time. And if you do that times 6, when you do 6 gallbladders, you're able to add on a 7th gallbladder that day and still get out at the same time. So that's not only good for the patients, but it's also good for your time, and basically optimizes your practice. Regional blocks, something that you see us doing. I really strongly feel if it were me, I would probably not want a regional block done post-operatively, depending on the type of surgery, but pre-operatively I would. I'll talk a little bit about this. Regional nerve blocks basically good for surgery distal to the injection. So if you block a nerve, if you block the sciatic nerve, whatever nerve you're going to do, you're able to basically operate at anything distal to that, depending on the concentration of the medicine that you gave, if it's really going to knock all of the sensation out. Preoperative benefits, minimizes anesthetic needs. I see anesthesia as a poison. And even the anesthesiologist in the room would probably agree that you don't want to just be sniffing a bunch of anesthetic gas for no reason whatsoever. And I feel that the best anesthetic that one could possibly give is the minimum amount of anesthesia and the minimum amount of medications that it takes to be able to achieve the effect to maintain a patient's hemodynamic stability and give them a good outcome so that they wake up and they're able to perform and function well. And from a surgeon's perspective, you should know this, and you should keep an eye on your anesthesiologist, because you could have a patient who rests the entire case with a blood pressure of 70/30, and they will wake up at the end of the case, and they may wake up really fast, and you guys don't know the difference, but 5 years from then, they cannot do math. So it's not just the short-term outcomes, it's the long-term outcomes, and for that reason, I like the idea of minimizing anesthetic needs. I mentioned a little bit about wind-up and sensitization. That's an advantage also of doing it preoperatively. It's hitting somebody's knee with a hammer when the orthopedic guy is doing a total knee. If there's a spinal in there, that transmitted signal is not going to make it all the way to the brain. It's okay later on when simply the pain secondary to it hits the brain, but it's not that overwhelming just got hit in the knee with a hammer sensation. And then there's less post-op pain medication equals less delirium. You guys know about post-op, ICU delirium that takes place. There's a large percent of geriatric patients that have delirium secondary to a lot of the drugs they're receiving, and it contributes to morbidity and mortality. The other thing about regional nerve blocks, they can be single shot or catheters. The idea behind a catheter is that it's going to continuously give the nerve block, whereas a single shot is just one-time thing that might last 6 hours, it might last 12, it might last 24 hours, but it's not something that's going to continue. So what kind of regional nerve blocks are there? Ankle block is probably the one thing that I think that you as surgery guys should know about, because like Dr. Mata, for example, actually asked me the other day, how do I do an ankle block? And he went to the ER and I told him, you read in the books and they'll talk all about the 4 different branches of the sciatic nerve and the saphenous nerve and all the different nerves that you have to specifically block. But the reality of it is you simply get some 0.5% ropivacaine, something that's strong enough that it's going to block all the signals, and you simply make a circumferential cuff of anesthesia all around the entire ankle. With the exception of just behind the Achilles tendon. You don't really need to go there. But that'll pretty much block all of the sensation of the foot. And you can debride a toe. You can even do a toe amputation with just an ankle block. That's awesome. A lot of those patients aren't exactly the healthiest people, too. Femoral and sciatic blocks are things that you'll do for the leg. Brachial plexus blocks, and this is also a distinction that's good to just be aware of. You guys hear people saying, oh, we did an interscaling block on them. Oh, supraclavicular, infraclavicular, axillary block. All that is basically saying is it's the exact same thing. They're simply the approaches to the brachial plexus. The reason that there's a distinction really is because it's where in the brachial plexus you're actually going to inject. If you do an interscaling block and it's up high in the neck, that's going to get C5, 6, 7, C8, might miss T1. So it's good for shoulder surgery, but it's not good for distal extremity surgery. Whereas if you do an axillary block, which is down here, you're going to get the lower parts of the brachial plexus. It's good for the hand, but it doesn't touch the shoulder. So that's where the knowledge from the anesthesia team can help to be able to determine what's going to be best. And in some cases, if you do a total shoulder, for example, or if you guys are doing some sort of vascular repair of a hand and you want to increase the amount of blood flow by decreasing the sympathetics, a catheter might be beneficial because that'll continue with that nerve block, it'll continue with pain relief, it'll decrease the sympathetics, help with flow. And then there's the beer block. This is basically where you put 2 tourniquets on somebody's arm, you put in an IV sterilely, you inject some numbing medicine. Generally, it's lidocaine, fairly highly concentrated. There might be some other anesthetics in there too. And you inject enough, so basically it fills up the entire vasculature of the arm. At this point, you inflate the distal blood pressure cuff and you deflate the proximal blood pressure cuff. The rationale behind that is because this blood pressure cuff proximally that you put up before you start injecting isn't an anesthetized area and it's going to hurt. But distal to that, where this other uninflated cuff is now going to be anesthetized. So then you inflate that cuff and you deflate this cuff and you actually have a tourniquet that's holding all of that medicine in that arm that's going to be able to not hurt and provide anesthesia for that arm. It's good for fairly short types of cases, but if you're doing something that's fairly simple in an arm, a distal radius fracture or something, which I know you guys don't necessarily do, but little things that Dr. McKee might do frequently can be beneficial with a beer block. Neuraxial blocks, basically very straightforward. The epidural continuous infusion, you put in a catheter. This is just kind of a little diagram of the different spaces. And a spinal is generally going to be a single shot. You could put in an intrathecal pump, or just a spinal catheter, excuse me. Generally speaking, though, you don't really see that done. We do these all the time, certainly in labor and delivery. The thing about a spinal is its duration is based on the concentration or the type of medicine that you actually use. So if you use something that's going to last longer, like bupivacaine or tetracaine, you might get a spinal that'll last 4 to 6 hours, whereas if you use a lidocaine spinal or chloroprocaine spinal, it might only last 1 hour. So we have to gauge what kind of surgery that we're having, and you guys certainly need to be aware of this stuff as well for how long to expect. Why is that? Because epidural hematomas take place, and what I thought was actually really important to recognize with this is when a patient has an epidural hematoma, the most common symptom that takes place is progression of the block. So you might have a patient that had an epidural or had a spinal, and they say, oh, no, I don't feel anything. But you start looking at it and you say, you know what? This spinal should have worn off 8 hours ago, and the guy's completely anesthetized from the belly button down. That's not a matter of waiting longer and seeing if the spinal goes away. It's a matter of emergently getting them an MRI and calling the neurosurgeon for their epidural hematoma. And we talk about these, and we talk a lot about the risks of epidural hematomas. And you guys hate, whenever you guys consult us, for things about getting like a thoracic epidural for somebody with rib fractures, and we'll say, oh, can't do it, they're on this, or can't do it, they're on that. Here's why. When you look at the relative risks, and this came out from the American Society of Regional Anesthetics, they have guidelines on what to do when it comes to doing these types of neuraxial blocks. This is the data that they supply, and it talks about whether you have traumatic. Traumatic means that you actually hit a blood vessel while you're putting in an epidural. There's a lot of veins in the epidural space. Just because you hit a blood vessel doesn't mean that there's anything that's going to happen. But if there is a little bit of bleeding on no anticoagulants, you see the risk, the relative risk that takes place with an epidural hematoma. Patients on aspirin, 2.5 the risk. Patients on heparin, you see where that goes, especially with a traumatic placement. Also, whether or not you wait before or after an hour to give the heparin after you actually do a lumbar puncture. Then, of course, you see heparin with aspirin. There is a significantly increased risk that does take place. So here's what ASRA recommends at this point. This is from the 2010 guidelines, and it's like 40 pages long or something like that. I will say I could not bring myself to read the entire document before this lecture because honestly, I didn't even start putting this lecture together until Sunday since I took the pain boards on Saturday. But what I did find here that I thought would be pertinent to you guys is surprisingly, when somebody's on BID sub-Q heparin, 5,000 units, they actually say that there is no contraindication to placing a neuraxial block. Now, you're going to find a lot of debate on that. And they do say that it may reduce risk if it's delayed. I would not put in an epidural immediately after somebody gets sub-Q heparin, ever. I would always weigh the risks and the benefits. I mean, if somebody's truly needs it for some reason, maybe you'd consider it. But you got to be very, very cautious about these things. But anyway, they at least state this. In terms of Lovenox, they say if it's prophylactic, you should wait 12 hours after the last dose. If it's therapeutic, they say to wait 24 hours after the last dose. The reason for all this is the peak onset of heparin, or of at least regular unfractionated heparin, is 2 hours. Peak onset after sub-Q Lovenox is 3 to 5 hours. So you have a sort of a different time frame. What's ironic about this is when it comes to, actually I'll get to it on the next slide, because the next slide talks about pulling them out. Indwelling catheters, they say to delay sub-Q heparin for an hour after a needle placement. That's sensible. It kind of goes along with what we saw with lumbar punctures. Sub-Q Lovenox, if you give it once a day, and this isn't once a day therapeutic with that 1.5 mg per kg. This is 40 milligrams sub-Q once a day for DVT prophylaxis. It's okay as long as you hold the first dose for 6 to 8 hours after placement. But if you're going with BID dosing, and that's both 30 milligrams BID or therapeutic, 1 mg per kg BID, those, they say, are contraindicated. There should be no catheter with BID dosing. They say to remove the catheter 2 hours prior to the initiation. In terms of removing the catheters, they say with heparin, remove 4 hours after the last dose and to assess the coagulation status. This is the reason that I personally would say I'd wait until at least 4 hours after sub-Q heparin before I'd place it too. They also say not to redose until 1 hour post-catheter removal. Okay. Sub-Q Lovenox, basically 10 to 12 hours after the last dose before you remove the catheter, and not to redose until 2 hours afterwards. Fairly similar to putting it in is taking it out. So enough about that. Let's talk a little bit more, once again, about maintaining patient comfort. And then I'm going to talk about PCAs, how to convert them, and what to think about when you're sending your patients out. So first off, when you guys admit pain patients, or any patient for that matter, look at their MAR. It's really easy to just admit a patient and stop all of their home meds and just put them on pain medicine. But if a patient is taking 100 milligrams a day of methadone and they're taking 900 TID of Neurontin, and you stop those drugs when they come in and you give them IV morphine, 2 milligrams every 4 hours PRN, they're not going to be comfortable. You're going to be hurting your patients. So continue their home pain medicines and consider the fact that that is their baseline. Their baseline with 100 milligrams of methadone and 900 TID of Neurontin is the same as my baseline without any narcotics, because I don't take narcotics. When you bring a patient in, though, you want to make sure that you consider the fact that their baseline is equivalent to their zero. So if somebody comes in for a gallbladder removal and you want to give them a little bit of pain medicine, keep their home medications, all of them, but then consider also giving them what you would give a normal patient. Give them an additional Lortab 5 or whatever else to cover the simple pain that you have from that procedure. The other things to consider is read old pain consults. There's a lot of patients that you guys have that are, they come in frequently to the hospital, and you guys will frequently consult pain management, and I'll tell you the truth, what we would do as a pain service oftentimes is look up the history and look at what we did last time and make the same recommendations. I don't mean that to be insulting. I just mean, because there's a lot of continuity, and sometimes even without getting the pain guys involved, sometimes just looking up the MAR to see what the nurses were giving them last time can give you an idea. And then also talk to them about whether or not they already have a pain doctor, because if they do, call them. I know that Dr. Day would love to know if one of his pain patients is coming into the hospital for something, and we're always more than happy to be able to come in and help to manage or optimize them, even if it's just a matter of giving some suggestions over the phone. So I'll talk a little bit about PCAs. You guys love PCAs. I love PCAs. Basically, advantages of PCAs are they eliminate the delay of the administration of pain medicine. And if you've ever been in the hospital, or certainly know people who have, you know that patients will ask for pain medicine, and it might take 20 or 30 minutes sometimes before they get their pain medicine. And God forbid they ask for it during shift change for the nurses. It may be even longer. Other thing that takes place, though, is the nurses need to draw up all of the medications. They need to titrate it. They might need to dilute it. They need to get a witness to be able to waste whatever's left over from every one of those doses. There's a lot of work involved. The PCA allows patients to be able to actually titrate their pain medicine to their level of comfort. It will also help to decrease, as long as you don't have a significant basal rate, or as I would generally recommend, no basal rate. And I know that your department says no basal rate. That is good. But the fact is, you have patients that are able to titrate the pain medicine to the level of comfort, and it also will help to minimize whether or not they're going to have respiratory symptoms and what have you. Basically, they're not going to be likely to press the button if they're too zonked out to do so. Also, there's less variability in the absorption of narcotics. What does that mean? I love this chart. This chart is basically showing IM narcotic levels in the blood on a regularly scheduled basis versus a PCA. And as you see, in terms of where the effective analgesia is, the PCA does a much better job to kind of keep that sinusoidal curve within a shorter frame. And this makes sense if you think about it. If you give a patient 5 milligrams of morphine every 2 hours, they're going to have an initial huge spike, and then it's going to drop after a couple of hours, and then it's going to have another big spike. So the PCA is able to really kind of keep things on a much smoother level. PCA dosing, this actually came straight out of Texas Tech. These are just kind of the generalized recommendations. The way I always like to think about it is start low, you can always go higher. You don't want to start somebody on too high of a dose of narcotic, but you don't want to start them on something that's not going to help them either. So look at the patient. There's no absolute right or wrong. In terms of which medications to give, meperidine, as you may or may not know, has an active metabolite, normeperidine. It's able to cause seizures. Generally speaking, you don't want somebody on meperidine long term. There are also some patients that have issues with their kidneys that will actually be able to seize. They say, I think it's like 1 in 6,000 people that have whatever the issue is. I learned this last weekend when I was doing the pain boards thing, but something that makes it so that they can seize from the initial dose. So it is possible to seize even from one single dose of meperidine. Fentanyl is a great drug because it has a very rapid onset. It doesn't last very long. So if you have somebody on a PCA and you want to simply see how much medicine does it really take to keep them comfortable, fentanyl can be a very good drug. Morphine is something that you guys give all the time. A lot of people give it. It's a simple drug. People are familiar with it. I actually personally prefer hydromorphone. I find less respiratory depression in the patients. It also doesn't have the amount of histamine release that takes place with morphine. Also in patients with renal failure, morphine's metabolite can also build up, and it is in fact an active metabolite. So just choose whatever drug you're going to use, but consider the reason that you're using a PCA. Now beyond the PCA, the fact is you put a PCA and it's not just a set it and forget it concept. It tells you what it takes to keep your patient comfortable so you know what to do next. So what do you do next? This is the section right here. I took this picture the other day. It's in the nursing/MAR restraint section of the chart. Inevitably that will change as soon as the new EMR system is doing whatever it's going to do. But it's this 24-hour PCA or flow sheet. And this was a real flow sheet from a real patient that I went upstairs. Obviously I covered up the patient's personal information. But what the nurses will do with these flow sheets, I guess I didn't have the zoom in page that I thought I did. What they'll do with the flow sheets is they'll actually say how much medicine was used from a certain time frame to another time frame. And you can basically calculate out how much pain medicine or how much of whichever drug you used was used over a 24-hour period in order to see what their needs are and what keeps them comfortable. So whenever you look at the PCA log, you need to ask yourself, is the patient comfortable? Now obviously that comes from talking to the patients. If the answer is yes, then continue the PCA as it is, or consider converting them to PO if they're stable and you anticipate that they'll be going within the next few days. Ideally, you want to keep a PCA for at least 48 hours. You want to be able to come up with some averages for how much pain medicine they really need, and also recognize the fact that because these patients that you guys have in the hospital are generally in acute pain and you expect them to get better, you don't necessarily want them to send them out on the same regimen that they're currently needing. So always bear that in mind. Also, don't wait until the date of discharge to send them out. Generally speaking, you're going to want to make sure that they're actually comfortable with the oral regimen. Always tell the nurses when you do convert them to an oral regimen to still give IV breakthrough medicine so that you can get some idea of whether or not it's all appropriate. But make sure that the nurses know not to give it unless it's really necessary. And also explain to the patients, because the patients might tell the nurses, I want the IV medicine. Well, they need to know that they can't always get that. And then, of course, there's adjunct medications that you can give. NSAIDs, muscle relaxers, Neurontin, Lyrica, all these other things can significantly cut down on how much narcotic you need to give the patients. If they're not comfortable, examine why they're not comfortable. And this goes back to the patient with buccal carcinoma. who was on 3 different types of narcotics by 3 different routes, a patch, a PCA IV, and pills, just to find out that all he really needed was Lyrica. And that came from describing the pain that they were having. Also, yeah, as I said, always consider other adjuncts. Cool. So here's where you calculate out the 24-hour total. And I won't really go through all of this in too much detail, but the bottom line is you can look and see, like with this, starting at 9 a.m., which is where I kind of went with on this, I consider it going until 6 o'clock the next morning where they put that last dose on there. And it came out to 7.4 milligrams of IV Dilaudid over a 21-hour period. Extrapolating that out to be what it would be over 24 hours, it came to 8.45 milligrams. Now, the reason that I say this is because you want to convert that to an oral regimen. Now, this is a guy who's, I don't know whether this guy just had surgery. He's probably not ready to get off his PCA because it turned out to be a lot. But you see all these charts that say here's how much one drug equals compared to another. You don't have to memorize this. You need to download this app or another variation of the app called MedCalc Pro. It's probably my favorite app. I did not know a better way to be able to show the icons, so you ended up with my wallpaper too. But they have opioid equivalence calculators. And so what I did here is show in the middle there 8.45 milligrams of hydromorphone, which is Dilaudid, is equivalent to 169 milligrams of hydrocodone PO. That's a lot. I'll generally taper by about 15 to 20% when I first convert them to PO. Still 135.2 milligrams of hydrocodone PO. So what do you do with that information? That's over a 24-hour period. So if we say we've got 135 milligrams of hydrocodone PO, divide that out by 6 and you get how much every 4 hours? That would be about equivalent to Norco 10-325, 2 tabs every 4 hours. Are you really going to send a patient home on that? No. The point is they need to get their pain better optimized. But the other point is you don't just DC the PCA and send them home with 1 Lortab 5 every 6 hours, give them 30, and then tell them that they're abusing it or selling it when they run out in a day. So it's just something to keep in mind to recognize that you can find out how much their needs actually are. Another example, and this is just a very, very basic thing, but morphine is real easy to be able to calculate because oral hydrocodone is a 1-to-1 ratio to oral morphine, and oral morphine is simply 3 times IV. So if somebody's using 20 milligrams IV in 24 hours, it's the equivalent of 60 milligrams PO in 24 hours, equal to 60 milligrams of PO hydrocodone, equal to basically 2, 5, 325s, basically 10 milligrams of hydrocodone every 4 hours. Simple enough calculation, but we can really optimize our patients by sending them out with the appropriate regimens. There's different kinds of opioids. Schedule 3s are considered weak. Schedule 2s are considered strong. They're pretty much all variations of the same. It's almost insulting how you have all these different companies that go and they make money because they have a different amount of Tylenol in the drug. The actual laws are changing. I believe it's to take place either later this year or actually it must be sometime next year, where 325 milligrams of Tylenol is going to be the maximum. They also just recently changed the recommendations. It's no longer 4 grams of Tylenol a day, it's 3 grams of Tylenol per day. But there's different variations of a lot of the same medications. Also, there's strong opioids, morphine, oxycodone, whatever. Percocet and Percodan are basically the only ones that are combinations that have Tylenol in them. The big discrepancy between stuff that does versus does not have Tylenol is when it has Tylenol in it, it has a ceiling dose. You can only give a finite amount of those pills before you're giving too much. Whereas with the Schedule II drugs, yeah, you could give too much because you'll cause respiratory depression, but they're not going to overdose on Tylenol. So you guys aren't going to so much be dealing with that, but at least just to be aware of some of the discrepancies. If anything else, to generally know that if it's mixed with Tylenol or it's mixed with ibuprofen, it's probably Schedule III, and if it's by itself, it's probably Schedule II. So in terms of selection of opioids, yeah, I already talked about the Tylenol stuff. Something that I think that most pain doctors should consider, I certainly consider, and you guys should also keep in mind, is absorption. If you guys have a patient that has a gastrectomy or somebody who's got short bowel syndrome, their absorption of a medication is going to be very different than somebody who's got normal bowel. So these are things that you might consider using a patch or using something that's an immediate acting. It's also something that if you have a patient who's on a long-acting drug and they do have short bowel syndrome, consider the fact that maybe they're not lying when they say that their pain is still bad. Maybe it's just that the medicine's not working because of their pathology. So when you send your patients home, make sure that they have enough medication. Do some sort of calculation. Make sure that you're really sending them out on an appropriate medication. And if you don't think about it, at least don't make accusations when they call in a day or two and say that they're still hurting, because they really very legitimately probably are. Also, consider follow-up for pain. Talk to their primary care doctors before you send them out. Let them know what you're sending them out on, and send them out on their adjunct medications. I was very disappointed when the guy with buccal carcinoma was discharged home and he was never given a prescription for Lyrica. And he came back in a couple weeks later in severe pain. And guess what? It was burning pain. And we started him back on his Lyrica, and it helped. It's very simple to be able to give these prescriptions to patients. Also, consider medication cost. Lyrica is a lot more expensive than Neurontin. It's not covered, I don't think it's actually covered by Medicaid. I'm not positive. Duragesic is not covered by Medicaid, but the fentanyl patch is covered by Medicaid. Go figure. So if you're writing a prescription, write it as a fentanyl patch. Also consider some bit of knowledge about what's in the Walmart $4 prescription plans, because those are things that our patients can afford. Always consider the fact that if a patient cannot afford their pain medicine, they're probably not going to go out and buy their pain medicine, and they're going to hurt. So that's the extent of what I had for you guys today. I hope that this is information that's beneficial to you guys. I really wanted to make sure that it was advantageous from a clinical perspective. So I'd love to discuss anything that you guys would like to. Thank you. By the way, it was truly an honor. Yeah.
Find out, as you mentioned, a lot of medications have a combination with Tylenol, and for some people with higher needs, it gives us a restriction in order to better control their pain with regards to giving adjuncts rather than trying to give monotherapy and try to titrate the dose.
Right. Honestly, I don't know. I really don't. I don't quite understand a lot of the reasons that some of our restrictions take place. In fact, they actually say that Schedule 3s are more commonly sold in the black market than Schedule 2s, probably because they're more available, because more people are actually prescribing them. But I don't know the basis as to exactly why. What's up?
The Rob was around the other day pushing IV ibuprofen as an alternative to Toradol in the post-operative period. Is there any?
You know how disgusted I am, generally speaking, with the pharmaceutical industry. I would probably go primarily with the fact that they have a patent on it and are able to make a lot of money off of it. I mean, it's certainly, any of the stuff is worth trying. Just like IV acetaminophen has worked really well with our patients. It's something to consider trying. The other thing, too, is, if I could, I'll take too long to be able to get back to it, but that chart that I have on here that shows about the different effects of the various NSAIDs, at least would give a little bit of a perspective. As you see, Toradol's on the very, very bottom. It's heavily COX-1 versus ibuprofen, which is, not nearly as COX-1. So it gets a bit more of the COX-2 inhibition. So it really it would make sense, at least pharmacologically, that it probably does have some advantage. But I can't really say one way or another without looking at the actual studies. But I'd certainly be critical and ask them to actually see their literature and see their data. I've never used ibuprofen. We use Toradol a lot, actually, especially like in L&D whenever the patients deliver. They do really, really well with it. Toradol's a great drug. A lot of people don't like when we use it because of its potential impact with platelets, and like the ortho guys oftentimes don't want us to use it. I'll always ask the surgeon before I give it. But in terms of anesthesia, it's a drug that's very commonly given and helping out with post-op pain control.
How many of you guys have tried to write the basic rate on the PCA? I'm going to show the system works because we took that off. The pharmacy is supposed to not ever do that and calling us if you write for it from another institution. We had a couple of years ago very, very sad cases, specifically the one dedicated to kidney stone and never left the hospital. And the reason was the basic rate on the PCA. So we have bad information about this part of the surgery. A couple of questions. Maybe it's just my perception, but are you seeing more of these people walking around with a diagnosis of chronic pain under the diagnosis of something that ends with myalgia, fibromyalgia?
Right.
I'm seeing a lot more of those patients than I think a few years ago. Is that a up and coming diagnosis, and they walk in here at the phone, there's all sorts of crap they have to deal with.
You're talking about syndrome or just chronic pain? Well, there's a couple of reasons for that, I'm sure. One is, in the state of Texas, when it comes down to prescribing narcotics for long-term pain control, you have to have a rational basis for why you're continuing to do that. And in a lot of these patients, you know that they hurt and that it's causing an impact on so many elements of their life. It's causing depression. It's causing what would actually be considered a syndrome, where it's impacting other systems secondary to the pain. In terms of fibromyalgia, or rheumatoid arthritis, or whatever it is, I mean, I think personally that fibromyalgia is grossly overdiagnosed, and we don't necessarily diagnose a patient with fibromyalgia, but when we're looking and we see a patient who comes in and they are depressed and they've got chronic low back pain and they've got other pains that are also bothering them and it's causing a true impact on their life, oftentimes that is something that will be considered syndromic. They will end up with that diagnosis of chronic pain syndrome as one of their diagnoses. But the other thing that I think is taking place, and we see it a lot with the pre-op anesthesia records, and I'm sure you guys see it a lot, the EMR just keeps track of every single little thing that somebody writes. And if a nurse asks a patient what medical problems they have, probably 10 out of 10 of our patients will say, oh, and I've got chronic pain, and the nurse will click it. So you're certainly going to see an increase in that diagnosis because the patients are telling them that, and it's going to stay in their EMR.
One more question. On the local skin incision, I don't do that on my patient. I don't believe it. One of the reasons is I looked at it a couple of years ago with some of the studies that you've been talking about. And if it's not done correctly, meaning that you do every layer, not just the top layer, and you do it and you wait long enough time to take it back, it's worthless. What's your opinion? I mean, that's what I see the best improved from other attendings. It's what your opinion, they're cutting right away. And based on the literature that I've read, that's not effective at all.
I think it's going to depend on the surgeon and the kind of... I certainly would never say that that's going to be the right thing for everything. I mean, if you're doing a thoracotomy, it's not going to make a difference. But from doing the anesthesia, you can always ask the anesthesiologist, is there tachycardia associated with when you do your incision? That's something that we'll certainly see. And it's actually quite impressive, because we did an epidural last Monday for a lady who was having a total knee. And we had the patient, the amount of anesthetic was half a MAC, which is equivalent to half of what it theoretically should take for them to not move to a surgical stimulus. And when they started the procedure, the vital signs did not change at all. And that whole concept, obviously, is just basically the blockage of the transmission of the signal to making it to the brain. And the idea about local anesthetic is the same thing. So I would say, I mean, if you're removing a lipoma that's fairly superficial and you put in local, certainly that would be something that would work. If it's a matter of insufflating the abdomen to take out an appendix or a gallbladder, it may not make as much of a difference. But I will say that when it comes to those types of things, if you at least do it superficially for the skin before you're closing, they'll be able to wake up a little bit more smoothly because you really can actually extubate them while you're still closing if it's something small enough. So the fact that it can turn around the OR a little bit more efficaciously, I think would actually be something that is still of benefit. The most important thing, though, in reality is it won't hurt to give some local. I mean, unless you give too much local, but I don't see much of a downside to it.